It is time for T4, and we have something good to talk about tonight. Of course, we have something good to talk about all the time. But this is something that as a dermatologist, you are going to see. And you are going to see it not just in your own patients, but probably in your family members and friends' kids. So this is something to be well versed in. So no matter what stage or age you are, knowing about infantile eczema, I think is really important. And so tonight we are going to just go over the infantile eczema. Next week, I am going to be jumping on and covering childhood atopic dermatitis because it is slightly different. And that'll round out our month of eczema awareness. October is Eczema Awareness Month. So we are hitting it hard on eczema. And then next month, we are going to move on to some more exciting topics with some of our host speakers. But let's jump right in to infantile eczema. And these are practical pearls. This information you may not find in a textbook. I can't give you exact statistics because it is based on my experience and what I've learned over the years. So I've studied this through textbooks, and I try and keep on top of the literature because we know that eczematous conditions are increasing, and it really consumed a big portion of my practice over the last 20 years, and it seemed to be growing over time as well. I've seen thousands of babies with this condition. I've learned how it clinically evolves, what works and what doesn't work, and even what makes it worse, which are a lot of things. And I've also held the hands of thousands of parents, many who were crying, who had babies with this condition because their babies were itchy and scratchy, and they woke up with bloody sheets and sleepless nights, not just for the baby, but for the parents. And then when nobody sleeps, everybody's fussy, including the baby. So I will tell you that seeing patients is truly on-the-job training, and it forces you to want to know more so you can help those patients that are in front of you. So you open the exam door, and this is what you see. You have this baby, possibly, or this baby, depending on their skin type. This condition is going to look a little bit different. So Dr. Lamb did a great job of covering the history of atopic dermatitis last week and pointing out the differences that we see in different skin tones. So erythema is definitely hard to see in darker skin, but you'll see it in a light skinned baby very easily. So you have this baby that has diffuse dermatitis. And then to add to the scenario, the baby's crying hysterically. The parents are looking at you desperately as the only hope to help them. So sit down, take a deep breath and smile, because you've watched this T4 talk and you know exactly what to do. So there are challenges in the newborn infants and skin barrier. And these next few slides are from CeraVe. I am a speaker and advisor for them. So these are from their slide deck. So I want to give them credit for that and all the work that they've done to quantify the skin barrier in children. So we do know that babies have structurally and functionally immature skin. As far as all of the functions of it. So at 34 weeks, they do have a well-developed epidermis. And by 37 weeks of gestation, you can see complete maturation of the stratum corneum. But the skin barrier actually takes up to 2 to 4 years to be fully formed and functioning. And that can be a slow process, especially if you might have genetic mutations or genetic changes that make you more susceptible to having skin barrier defects. So this is a good table of the differences between infant and adult skin. So in infants, the epidermal thickness is thinner, cell attachments are less, the DE junction that kind of keeps the skin together is flat, it's not undulating, the lipids are less, melanin, sweat less, water content is actually higher, as well as the pH, but their natural moisturizing factor concentration is lower. So all of these things really set babies up to have sensitive skin to the outside world. They also have a lower skin immune system, and their skin microbiome is similar, but they do have higher rates of staph species and other bacteria that colonize the skin at birth. So Like we talked about, the stratum corneum is not well developed during the first year of life. It evolves and again can take up to 2 to 4 years to fully mature, but the skin surface pH is elevated. And it needs to develop that acidification or that acid mantle that sometimes people will talk about to get to the physiologic pH. And they showed that this acidification and hydration takes place during the first few weeks and again continues on for many months to years. So this is what a baby looks like when they first come out before the nurses get their hands on them. And this is a photo from one of my colleagues, LaTanya Benjamin, who is an amazing pediatric dermatologist. And this vernix caseosa, is very important to the function of the baby for many, many reasons when they first come out into the world. It forms during the last trimester, so the third trimester. It consists mostly of water-containing corneocytes, but they do have this lipid matrix. And you can see here the vernix is definitely different than the postnatal stratum corneum. It has more cholesterol and more free fatty acids and less ceramides. And then that ratio kind of flips as the skin matures. It does waterproof the fetus in utero while it's submerged in the amniotic fluid. And it also protects as the baby comes out into the world through the birth canal. So has a big function, not just internally, but also in the process of birth. And then after birth, it actually functions as to protect the neonatal skin because it is immature. It also increases hydration, suppleness, and plasticity. And then the nice thing about it is it inhibits pathologic bacteria growth and facilitates the commensal growth of bacteria that keep our skin healthy. And again, this is not static. It is a changing process. But the vernix has so many great properties that are helpful to the skin of babies. So the question really is, why do we remove it? Well, we all know why. It doesn't look good in baby photos. So it's really more about appearance. But there are different organizations that have spoken out and said we really should let this vernix fall off or come off on its own over the first few days of life, because it does provide for this immature barrier so many of the functions it needs. And there is question that maybe if we left it on, there might be less eczema. So basically, you have a baby. They're essentially an aquatic being. They've been floating around in this pool of water in the amniotic fluid for 9 months. And then they come out with the vernix, and then we remove that protection, that only protection that they come out with into the world. And then we release them into the wild, if you will, as a terrestrial being. And we put them in the hands of parents who likely have no idea what they're doing at first, because I will tell you as a parent, it is the most overwhelming experience that you will ever face. And on top of this, skincare companies are great at marketing, but they're not always great about making products that are best for neonatal skin. And unfortunately, I think this is really kind of mind-blowing to me, but babies are exposed, their immature barrier is exposed to a significant amount of environmental chemicals in the first month of life, the first few weeks of life. So many kiddos, babies will have up to 10 or more skin care products used on their skin in the first 4 weeks and be exposed to, again, almost 60 upwards of 60 environmental chemicals, many of them that have not been studied in children in those first few weeks of life. So this is how I believe, in my experience, that infantile eczema starts. It starts with what a lot of people, physicians, pediatricians, and then also even dermatologists diagnose as baby acne. And as you can see here, I pulled these pictures from online and they were labeled with the tags for baby acne incorrectly. This condition is actually not baby acne. Some people used to call it milk acne. But what it actually is neonatal cephalic pustulosis. And some people also refer to this as neonatal Malassezia furfur pustulosis, because we do know that Malassezia species are thought to be the causal agent of this condition. And it is a neonatal variant of pityriasis folliculitis. And it will typically present in the first 4 weeks of life with these erythematous papulopustules, as you see here. They might have a slightly erythematous base. You'll see this more on lighter skin, where on darker skin you might not see quite as much of that erythema. But those fine papulopustules that are fairly diffuse, they tend to be on the cheeks, chin, eyelids, neck, and upper chest. And the neonate is otherwise healthy and growing well. And treatment is usually not required. It is self-limiting, and it usually resolves within 3 months without scarring. But you can use topical ketoconazole on it, and it can be beneficial just because it treats that underlying cause that is driving the inflammation on the skin. So where are other conditions? Where do we see conditions that are associated with Malassezia furfur or Malassezia, depending on how you say it? I will tell you that it's an infantile seborrheic dermatitis. And this was a nice article that looked at what percentage we find it in different skin conditions. And they found that 42% of infants with infantile seborrheic dermatitis, what had been diagnosed as infantile seborrheic dermatitis, had positive smears and cultures from the scalp, face, presternal area, and inguinal area for Malassezia species. So interesting that that plays a role not only in neonatal cephalic pustulosis, but also in infantile seborrheic dermatitis. And I do feel like, in my experience, that infantile eczema kind of goes through this process and presents first as a little bit of the neonatal cephalic pustulosis, which then eventuates into more of this seborrheic dermatitis. And I do think that that commensal yeast is overgrowing a fair bit, that induces this inflammatory response in the immature barrier of a neonate. And infantile eczema, it's not just cradle cap or seborrheic dermatitis, but it also involves the face and the skin fold. So this is very common for what gets diagnosed as infantile seborrheic dermatitis in babies. So it tends to involve the face, and then very significantly involves the skin fold. So the neck, the axillary area, the inguinal area, and then you can have this diffuse finding throughout the skin. I'm going to just move a little bit. The sun is in my eyes. So let's move you this way. All right. Well, that didn't make it any better. Okay. So anyway, classic picture of infantile seborrheic dermatitis. But again, what's in a name? Potato, potato, tomato, tomato. Let's call the whole thing off. And this is actually from where that song's from. And I would encourage you to go out and find this in the old internet memes and such, because it's a fun little song. Potato, potato, tomato, tomato. Let's call the whole thing off. Anyway, I'm a lover, not a fighter. I'm also a lumper, not a splitter. So for me, I would diagnose each of the following conditions and the previous ones that we just saw that kind of are classic infantile seborrheic dermatitis as infantile eczema. And the reason I do that, again, is because I'm a lumper, not a splitter. And it also doesn't impact my recommendations for what I give the parents, the treatment regimen. So I really think that it's kind of splitting hairs. And I think people understand what infantile eczema is, where when we use the word seborrheic dermatitis, that can be confusing. And then they go out on the internet and they look it up and they see, older gentlemen that have it. So again, I think this just explains it in a way that people understand it. I also think that they really are in the same spectrum or the same condition, again, that eventuate from kind of that neonatal cephalic pustulosis, probably have a little bit of an overgrowth of Malassezia. That eventuates into that seborrheic dermatitis phenotype, just because of the fact that Those yeasts do like to grow in areas where we have more sebaceous glands, which are in the skin fold, scalp, and face. And again, I just really consider that infantile eczema. I would also call this infantile eczema, and this infantile eczema, and this infantile eczema, and this infantile eczema, and this too, infantile eczema. So again, I think it has a lot of variability, but I think it all relates to a very similar pathophysiology. And again, it doesn't modify my treatment recommendations. So what I call infantile eczema in most babies, it will improve. And in my experience, about 75% plus will resolve over 2 years. Therefore, I never diagnose a baby with atopic dermatitis until after 2 years of age. I always call it infantile eczema within these first 2 years. I let the parents know that it gets significantly better around the 1 year mark as the skin barrier matures. And then usually by 2 years, we don't have any more flares and it's completely gone. And that's going to be in the big majority of patients. So it's really nice to be able to give that reassurance to the families that their baby, has this eczema. It really is related to this immature barrier that is going to mature over the first few years of life. And as the barrier matures and starts to do all the things that it's supposed to do, this condition will resolve because they'll be able to better maintain moisture in their skin. The lipids ratio will even out, their ceramides will increase, they'll be able to increase their hydration because the natural moisturizing factors also increase. And again, I think this is just really going from that aquatic being to this terrestrial being that happens in an instant, and that baby having to mature the barrier to live in this terrestrial world. So again, about 75% of kiddos that have infantile eczema are going to get better significantly. Most of them get better by 1, but again, as the barrier matures, and some people are a little slower with that, it's usually gone by 2. Now, about 25% of these babies are going to go down the golden path of atopic dermatitis. And again, I don't diagnose a baby with atopic dermatitis until about 2 years of age, when I see that they're going to kind of fall into this 25%. And I equate it to reactive airway disease. So as far as pulmonologists or even pediatricians, when a baby first wheezes, when they're under 2, they never diagnose the baby with asthma. They diagnose the baby with reactive airway disease because, again, the airways are also maturing. But we know that if it persists, it likely the baby has some genetic factors, environmental factors that have set them up to have a stronger inflammatory response. And this is going to be more chronic, and they'll diagnose the baby with asthma. So again, babies stick with the name infantile eczema in my clinics until they're about 2 years of age. And then we'll kind of be able to tell which course they're going to go down. About 75% will get better, 25 will go on. But that's a nice reassuring kind of round number to share with the families. And again, based on my experience. And I think the ones that do go on, they may have a filaggrin mutation. They have shown that up to 26% of kiddos with atopic dermatitis have a filaggrin mutation. And I do think there's probably other genetic changes in skin barrier components that make them more prone to go on and have what we call true atopic dermatitis. Now, if they do go on, it's also reassuring to let the families know that 85% of kiddos are going to get better by 8, and about 95 are going to get better by 20. But there are going to be some children with childhood atopic dermatitis that will persist into adult atopic dermatitis, but the huge majority are going to get better. So again, lots of reassurance in that first visit with baby eczema. So the one condition that I do try to differentiate is irritant contact dermatitis. And the reason that I try to differentiate it is because it impacts the anticipatory guidance that I give to the family. And basically, anticipatory guidance is just a fancy word we use in pediatrics that basically means what to expect, right? What is the prognosis for your child? And how do we think that treatment is going to impact that? So irritant dermatitis is very common. I would say almost 100% of infants get some degree of irritant dermatitis at one point or another. The way to differentiate this from what I call infantile eczema is it's only on the face and neck. So you really don't have it elsewhere. It's typically bright red. It can be symmetric, but it is fairly well demarcated. It's on the cheeks and the chin. Sometimes it'll be on the tip of the nose, and sometimes it can come down here. May have some fine papules in it, might even have a little scale, and it might even have some serous crust. I do find that a lot of times it will get so beefy red, and the barrier is so disrupted, usually made worse by the things that people are using to try and treat it. And it can actually ooze to the surface and become very crusted. And a lot of times this gets misdiagnosed as impetigo or secondary impetiginization, when a lot of times all it is just that inflammation that's just boiling up to the surface. It is very irritating, and babies tend to rub a lot. They'll rub with their fists and make it worse. They'll rub anytime anybody picks them up. They'll kind of, parents think the kiddos are trying to snuggle in, but they're really using their shirts or their neck to kind of rub their irritant dermatitis on the skin. Or you'll also put these babies down and they'll use the crib sheets a lot of times. Another way to know that babies are itchy, because they don't scratch, they don't have that coordinated effort. I always tell my families that, babies with these itchy skin conditions, they tend to be the ones that are movers and shakers, like they just never kind of relax and sit still when you're holding them, because they're itchy and they just don't know how to scratch yet. The other thing is, a lot of times you'll put a baby down in a crib and you'll put them down here, and then because of the moving and the shaking to try and scratch, they end up kind of across the crib, even early on. So if you put a baby down and you find them in another place in the crib, it probably means they were trying to scratch. And this irritant contact dermatitis is always going to be worse after eating. And it's because the food gets on the face. And it can also get worse too if a mom's breastfeeding and she's holding the baby up close. Just that skin to skin contact can be irritating. It gets warm, and anytime the skin is warm, any of these inflammatory dermatoses are worse. So you'll always hear babies with irritant contact dermatitis or infantile eczema, when they get out of the bathtub, it's more red. And a lot of times I like to just point that out to families, and let them know that we get more blood flow when our skin is warm as a way to release heat. And so that it's always going to show up a little bit more red when babies just get out of the bathtub. But just reassure the families that it's worse just because of the contact with food or the contact with the skin when breastfeeding, but it's not because of a food allergy. All right, oops, backwards. Let's go forwards. So what do you do about it? What do you do about irritant contact dermatitis in a baby? I will tell you, it is a tricky condition because parents just want it gone because they're taking pictures of their baby all the time, and they want them to look cute. They want them to be Instagram famous from the start. So you really have to counsel them about avoiding contact irritants. And there are so many of them out there. So no diaper wipes or boogie wipes on the face, ever, never. And you can have parents either use I like Bounty paper towels, they're a lot softer, and just use tap water to rinse the face, or they can get soft baby washcloths and have those in a stack in a basket by their sink, and they can use those and clean them each time. So that's what I recommend for washing after a baby is eaten. It is always worse after eating, as we talked about, especially if there's acidic or dyed foods. And again, remind them that this is not an allergy. It's just because of the contact of those irritating foods on the skin. Now, the other thing we have to think about too is babies do develop allergic contact dermatitis. Kind of the thought in the past was that they wouldn't develop, they didn't have time to develop contact allergies, but they can develop. And I have seen babies that are patch test positive. So again, gentle skincare products, And there are so many products for babies. It's overwhelming for these poor families. And I will tell you, I go to the skincare aisles in CVS and Walgreens and Target every once in a while, and I will go through the baby products. And most of them, when I flip over and look at the ingredients, either active ingredients or inactive ingredients, they are products that I would not recommend. Fragrances are common in all things baby. And they're very irritating to babies that have a more sensitive or more immature skin barrier. The other products that really trigger a lot of contact irritation and allergy in babies is organic products. And that are those plant-based products. So a lot of baby companies have put these in. Again, it sounds great. But in the end, when I tell parents that poison ivy is technically organic, and when you put a bunch of leaves and plants and flowers crushed up in a cream and you put it on a baby with an immature barrier, the skin is going to react much like poison ivy. So again, just kind of sharing that with them. So the lavenders and the chamomile and the shea butter and all of those things that get put into baby products, oatmeal, all of those things can be irritating in a sensitive skin baby. So if I have a really sensitive skin baby, my very favorite products are Vanny Cream. I do again speak for CeraVe, but when I have a uber ultra sensitive baby, I do think the Vanny Cream products do a little bit better and they burn and sting less. So I recommend them to be kind of Vanny Cream exclusive if they have significant infantile eczema. Also for this irritant contact dermatitis, I think it's really important to apply a thick coat of ointment before eating and sleeping. And the reason that is because drool, which we can't control, is a very irritating substance for baby skin. And unfortunately, babies drool and they continue to drool. And I did have one mom tell me, she's like, I swear this drool is like sulfuric acid. And I almost agree with her in seeing irritant contact dermatitis. So again, because this barrier is immature, because it's already irritated, and because the things that are irritating are going to keep happening, we just want to put that thick coat of ointment. I tend to use either plain petroleum jelly, Vaseline petroleum jelly, or also the Vanny Cream ointment. You do have to tell them to be careful not to infect the tub, because a lot of times patients will take that tub of ointment, put their hands in it, and then put it on the baby's face, and then maybe get more. And again, then that tub of ointment becomes a petri dish. So again, make sure that they're just opening it up, getting out a disposable spoon or a spoon that they wash after each use, getting it, putting it on the spoon, and then getting it off of that. I do recommend 1% hydrocortisone ointment, not cream, because a lot of the creams can even have, again, preservatives in them that can cause the flares. So 1% hydrocortisone ointment over the counter can be used intermittently. I usually only recommend a few days at a time. And if I do warn them about the perioral dermatitis, which can develop where, you know, steroid rosacea, if you will, or the infantile perioral derm. So again, try to get them to doing good skincare, limiting the irritants and allergens, I think is the biggest part. But every once in a while, when it gets really inflamed, to help clear out that inflammation and let that barrier heal so it can do what it's supposed to, we need a topical steroid. And sometimes I'll even go stronger, a mid-potency. For just a couple days, I give them the smallest amount that I can. And that's just to break the cycle. Otherwise, again, because what's irritating keeps happening, it can be hard to heal. I also see a lot of people in these situations, and I'll flip back here quickly. They will add a lot of antifungals for this. And I will tell you that a lot of times, again, I do think that Malacia plays a role in this condition, and antifungals can help with that. But it really is that inflammatory response that is causing the dermatitis. And I think that is what causes the symptoms. And I think if we can get the inflammation out, the barrier can heal, and then the body takes care of those commensal organisms on their own. So again, a lot of people might recommend doing a topical antifungal in seborrheic dermatitis, but again, I think it really just causes a lot of irritation. So again, avoid antifungals if it's weepy. Again, the word eczema, as Dr. Lamb taught us last week, means to boil over. So do not assume it's impetigo. And then again, just give your families anticipatory guidance that this is going to be recurrent and difficult to control, because what is irritating will keep happening. They're going to continue to keep getting food on their face when they eat, and they're going to continue to drool. And once they're able to feed themselves and their drooling resolves, then their irritant contact dermatitis will fully go away. So kind of switching gears, very similar to irritant contact dermatitis for infantile eczema. These are my treatment tips. And again, they all revolve around skincare, skincare, skincare. I do think daily bathing is important. I do think it helps to get hydration back into that skin barrier, because again, we know these babies do have less of those components of their skin barrier that keeps moisture in. So you have to bathe correctly. So a daily bath, but using the right products. Again, for really sensitive kiddos, Vanny cream products are my favorite. If the skin is eroded or open, or the family's worried about an infection, I do recommend a dilute bleach bath. And I reassure them that the very first study was done here at Baylor, a local Houston institution, and it was done in the NICU on babies with very immature barriers, and they didn't have any issues. Don Burrows, and this is a little bit astringent. I do use that if it's just that beefy, red, weepy, presentation. The Don Burrows, you can get this as a tablet or a packet. It's over the counter. You add that into water. I have them put that in the refrigerator, and then I have them get just a soft cloth and soak that in there, and then just hold it on the cheeks. It does burn and sting a little bit, so the babies aren't going to love it. So again, I don't add that in unless the skin is really weepy and we're seeing a lot of that serous crusting. And again, if you do think it's secondarily infected or impetiginized, I think it's really, 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 really important to culture, because I think a lot of these babies get exposed to topical and oral antibiotics when they don't need it. And we know that impacts their gut health, and then that has the downstream effect of affecting their eczema and their atopic march. And again, less is more. It's a saying I use a lot when talking about infantile eczema, because the less products we put on our baby, the less they're going to be sensitized, the less things are going to irritate their skin, and the less they're going to develop sensitization and contact allergies. The other thing that I think is really important and simple, low-cost intervention that can be done is moisturize from day of life 1. And the reason I think this is important is that skin barrier, it looks like a brick wall. And we know that the bricks, the skin cells are there, but what's kind of lacking and what's more mature is what kind of holds that together. So again, I think the studies that show this, and there are now many studies that show that this is a great way to limit potential atopic dermatitis down the road. And I think really what we're doing is we're putting that artificial barrier in place so that the skin barrier can mature over time, and then we're not getting all of those sensitizations in that can lead to the atopic march. So treatments that I prescribe, I do like low potency topical steroids in infantile eczema if a baby needs them. Because again, it won't break that cycle of inflammation and scratching, which damages the barrier. And then you get into this vicious cycle of itch and scratch. So low potency topical steroids, I do go over the classes with my families, class 1 through 7, 7 over the counter. I tend to prescribe class 6. I really like fluocinolone oil. It does have peanut oil in it, but it's very purified, and even babies that would have peanut allergy don't seem to have any reactions at all. And I have used it in kiddos that are anaphylactic to peanuts, and they've done just fine. But appropriate use. My way of using topical steroids, I'll go over this again next week when we do childhood eczema, is 15 days per month. And I let them kind of use it when they need it and back off when they don't, with the touch point of never going over 15 days per month. And you really do need to address steroid phobia, especially in parents of young babies, and tell them that yes, you know, there are side effects, but you're going to monitor it. I also don't put refills on my topical steroids when I prescribe them, never, ever, just so that I can monitor how much they're being exposed to. The other thing that's really important is to give them the anticipatory guidance of post-inflammatory hypopigmentation, that this is actually just a result of the inflammation from the infantile eczema being in their skin, and it's not a result from the use of the topical steroids. This is really important in babies of skin of color. I do use off-label the topical immunomodulators, pimecrolimus and tacrolimus ointment, if they can't achieve that steroid holiday, which is 15 days or less a month, because some kiddos that have real sensitive skin, again, probably have filaggrin barrier issues, and changes in their DNA that make them a little bit more prone to go on and get that atopic dermatitis. And again, if they can't get less than 15 days, I start to worry about the steroid side effects, and we'll add these in kind of for their mild flares. And then it's also important to address the itch and to treat it appropriately. It not only improves sleep for the baby, but also the parents, and it improves mood for both of these as well. And then just remind them there are side effects to untreated eczema, not just that the baby's symptomatic, but we do know, and there is some evidence that this atopic march happens because of the sensitization that happens through the barrier. So with the atopic march, we see eczema developing first, followed then by food allergies, asthma, and rhinitis. And if we really aggressively treat the skin, that barrier that prevents that downstream sensitization of the immune system, I really do believe that we can prevent some of this atopic march, and prevent these other downstream effects that can happen. So what about food allergies, Doc? I will tell you, they do not cause eczema. And again, I think this is something that is a huge misconception among the medical community, and online. And I will tell you, the allergists are now on board, and they've also started to share about food allergies not causing eczema. So type 1, reactions are urticaria and food allergies. Those are going to happen immediately, but eczema is more a type 4 delayed hypersensitivity reaction. And that's why kids with eczema are way more prone to get allergic contact dermatitis, in addition to their eczema, because they're type 4 reactions. As far as type 1, these kiddos that are prone to have food allergies, you're going to see it manifest in their skin as urticaria and facial and lipedema. So I ask about that for families. If they do get those things, and if they are not getting, again, urticaria, facial or lip swelling, I don't have them change the diet. I don't recommend any diet recommendations. And here's some food for thought. Restriction diets do not uniformly help clear eczema symptoms, and they can, I have seen this, result in nutritional deficiencies. A lot of questions around breastfeeding. Basically, there's lack of evidence to support that maternal dietary restrictions in pregnancy or lactation are needed. So high-risk infants, they do show that if you breastfeed for 4 months, it will decrease the incidence of atopic dermatitis, but really no additional benefit in preventing atopic derm past that period. There are other benefits, but there is no benefit in delaying solids beyond the 6 months of life, even allergenic foods. But again, that goes off the table if we're noticing urticaria, if we're noticing facial or lip swelling. And then the newer literature, again, is showing that there is no relationship with introducing solids to a baby. The World Health Organization recommends the age of 6 months to start introducing those, just because the baby's better able to tolerate them developmentally. And then again, early introduction of food allergens have been associated with actually decreased risk of food allergy. So they're recommending early introduction of allergenic foods, because then we can become more tolerant of those early on and not have a big sensitization reaction to them. So please, please, please reassure parents that they do not need to avoid foods if their baby has eczema. Again, the caveat is that urticaria or facial and lip swelling. and then let them focus on the issue that's causing the problem, the skin. So again, we know that skin barrier is immature, and we know that's where we get into trouble. So again, instead of focusing on food allergies and removing all of these things from their diet, if they're breastfeeding, or the baby's diet, or changing formula, really just focus on the skin. That's where the problem is. And then when a baby loves the skin they're in, then the parents' stress level decreases significantly. And there are so many studies that have proven the high level of stress for caregivers, especially the mothers. And there was a study that came out that actually showed that mothers, even after their babies grew out of infantile eczema, they still woke up more so in the middle of the night and didn't get into REM sleep very often, sadly. It is critically important to have a therapeutic alliance with the parents. If they don't, if you just come in, Bree's in the room, Bree's out of the room, and, have your medical assistant give them a prescription that you haven't explained, they are not going to use this. They are very protective, mama bear, with their babies, and they should be. And it is in their best interest to have the education and the knowledge that they need. And again, parents don't know what they don't know. And it's our job and our responsibility as their caregivers and medical professionals to give them the information they need to make good choices and to help their babies. I think it's really important to articulate that you understand the stress this condition causes in their household. And again, just knowing that you are there for them. And again, refer them to Made a Masterpiece for a community that understands and can provide support. Because again, so many of these mamas and dads feel so alone. So again, the triple trifecta: a happy baby, a happy family, a happy physician. And this is all, of course, compliments of your T4 teaching here tonight on infantile eczema. All right, y'all. I think I'm going to use a different room next time that doesn't have the sun blaring in. Luckily, I have on my sunscreen as my only skincare secret tonight. But are there any questions in the chat? I don't see that there are. So I am going to jump off, but I hope you look at this often, as often as you need to take good care of those babies so that they can love the skin that they are in. All right, guys, have a great night.